Very much. Hello, everyone. Thank you for joining. My name is Dr. Jeff Orr, one of the local orthopedists here. And today we're going to be talking about total joints in general, and we're going to have an emphasis on the same-day joint replacement, which we have recently started doing here, which is fairly timely for us given the COVID environment. Limiting your time in the hospital is a nice addition that we have, that we're able to still provide our total joint replacements. So moving through. So why are we talking about this today? Joint replacements are rapidly becoming, if not already, one of the most common orthopedic procedures in the United States, and is projected to increase exponentially. On this slide here, you can see that total knees are very popular. Over 1 million are done every year in the United States alone, and quite a few total hips are done as well. The reason for the disparity between doing the knees and hips, knees tend to wear a little bit quicker. You have your dreaded meniscus tears that occur. Kneeling on your knee, people tend to fall on their knees more commonly than on their hips. So knees just tend to wear out a little bit quicker, and ergo, the total knee replacement has become a little bit more common, although total hips are also fairly common surgery. So why do we do these replacements? What's the main cause? Typically, we're doing these replacements because people have pain. And there's several different reasons that we develop pain in our joints. So first and foremost, and probably the more common one, is osteoarthritis. And osteoarthritis simply refers to mechanical wear and tear. You move your joint around enough times, it's just going to grind down eventually, and the cartilage starts to thin out. And as you lose your cartilage, you lose your cushion in your joint. And if you lose your cushion, then you develop more pain and inflammation and pressure, and all that basically adds up to not having a very good time. With this x-ray here on this side, you can see it's a fairly well-maintained joint. The head appears to be fairly well-rounded, and there you can see that there's a little bit of joint space in between. Although this is, not an 18-year-old hip, there's still some good viability here. On this other side, you can see that there's not any joint space. You can see that there's bone spurs as well, and you can actually see that there's a little bit of some pitting going on as well, or some cyst formation. So this hip is fairly advanced in its arthritis on this side. Another cause is post-traumatic arthritis. So if you have an accident in your knee, the pain, swelling, inflammation from that trauma tends to accelerate the loss of cartilage in that knee as well. And so with this patient who had an injury when they were an athlete back in high school and had a multi-ligament reconstruction, they just had accelerated joint wear in this knee as well. Another cause is inflammatory arthritis. This is chondrocalcinosis. You can see some calcium that's been deposited along the cartilage right here, and this causes inflammation on its own, and this can also lead to increased inflammation, pain, and discomfort in this knee here. And then a last important cause is osteonecrosis, when you have a limited blood supply to a joint and you start developing joint or bone resorption. In this example here, this femoral head is asymmetric because this lady has not had good blood supply, and so the head actually starts to be resorbed by the body. And this can also, again, you can see that there's not very good joint space, and also causes quite a bit of pain, discomfort. So what can we do about this? Surgery is typically not the first thing. This is my daughter, Lakey. Please go ooh and ah as we continue to talk about things we can do. When we see someone who has joint wear and tear, the first thing we try to do is get that pain to go away with the least amount of effort that we can do. So, and there's several things we can, get to help us instead of jumping straight into the surgery. So, first and foremost, easiest thing to do, if something hurts your joint, don't do it. So if hiking bothers you, going up and down stairs bothers you, running bothers you, there are certain things that to a point you can try to cut out or limit doing. Another option is physical therapy. Physical therapy will help calm down some of the inflammation in the joint. It can help improve your range of motion. So if your knee or your hip are very stiff, then you can help work on that motion. And if you have muscle imbalance across a joint, it can also help even that out. So if your quads are very strong, your hamstrings are very weak, or vice versa, you want to get things so that it's much better balanced, and that can help improve joint motion. Anti-inflammatory medication is also a option. We try away from using medication. It's very helpful. These are you can also use topical application. So you know, try to get contraindication to using anti-inflammatory oral medication. But this can also be very effective. Injections are a very useful tool that we have. Corticosteroid injections are fairly helpful and fairly commonplace. We also use hyaluronic acid, which is a naturally occurring substance in your knee, and we supplement that through injections that help keep the cartilage happy. PRP injections, which is platelet-rich plasma, along with stem cells, are also options, and that is a whole lecture unto itself, and we're not going to dive too much into those, but those are also options you can certainly ask your doctor about if you'd like. And these are all non-surgery options that can be pretty effective in terms of getting the knees to feel better. At some point, the non-surgical options are not as effective. The steroid injections or the other injections tend to be less effective the more you get and as time goes on. And as the knee or the hip wears down more, at some point, the non-surgical stuff just isn't going to work anymore. And then it's time to have that discussion about having a surgery done. So going through the different types of surgeries that we do for replacements. So total hip replacement is composed of several components. So there's the pelvis side, which is called the acetabulum, which is this shell here. And then the femoral side is this stem right down in here. Okay, now these can be made of titanium. These can also be made of cobalt chrome, which is an alloy of metal. And then in between, there's plastic and ceramic or metal that creates the recreates the joint to help the hip move again. For a knee replacement, we replace the bottom of the femur and the top of the tibia, and there's plastic in between, and there's also plastic that goes behind the kneecap as well. And this is demonstrated here. So this plastic is a very highly specialized piece of plastic that has very high mechanical wear rates, and it's very strong. So it lasts for a very, very long time, same as the hip. For people who only have an isolated arthritis, we're able to do a partial replacement where we only replace one compartment of the knee and leave the rest of it alone. This makes the surgery a little bit shorter, recovery a little bit easier, and the incision looks a little bit nicer as well, which is always a bonus. Here are the components of the partial knee replacement. It's very similar to a total knee, just smaller. Now, what we have just started doing is this procedure, but now on an outpatient or a same-day discharge basis, which is very similar to doing an inpatient surgery. But there's a lot more emphasis and there's a lot more work on the pre-surgery side. So first off, in the office, making sure that you have a good medical history, that you understand if there's any issues such as diabetes, blood pressure, cardiac disease, things like that, that we can catch ahead of time or that we can correct. Anything that we're unsure of, we do pre-surgical testing, which involves lab blood work, any additional chest x-rays, heart evaluation, or any additional consult from other medical doctors that we need. There's also a total joint class where we use one of our liaisons to help guide through what is going on, when your surgery is, and how to time everything and what you need to do to prepare. And preparing includes providing prescriptions that you may need for after surgery, which is pain control, nausea, things that help prevent blood clots as well. So there's some medications there, and then also any additional equipment if you need a walker or additional handles, things like that. Special beds as well if we need. The day of surgery is very similar to an inpatient total joint surgery. We have patients fast from midnight the night before. They are allowed to have some liquid the day of, but typically nothing to eat. When you're in the pre-op area, they start an IV. A regional nerve block is done to help prevent post-operative pain, and general anesthesia is done when you get into the room, and that can either be a spinal, which is an injection in your back, or intubation. We also give you some pre-op medication as well to help with post-op pain also. The surgical procedure has not changed from an inpatient surgery to an outpatient surgery. The same components are used, the same approach is used, and that does not have any effect on whether patients stay or whether patients go. The post-surgery discharge criteria is a little bit more stringent. Patients need to be able to eat, to drink, to be able to use the restroom and urinate, and they have to be able to ambulate on their own or with assistance with a walker or crutches. Day after surgery, so if all the criteria are met and you are able to go home, then the next day we have a home health person come, which is a nurse. We also have a physical therapist come to work with you a little bit just to help you get around the house and get the joint moving. And then our nurse navigator will also give a call. So there's very close follow-up the day after surgery for an outpatient total joint surgery. So does this work? All right. We have just started this program in the past couple of months, which has been spurred on a little bit because of the COVID era, and we are limiting people's contact in the hospital, which is always a beneficial thing. It also helps with pain control. Being at home, people can be a little bit more relaxed, and people tend to be a little bit happier, and studies have shown this. And risk of infection also tends to go down. And this slide here is meant to show that as the hip and knee market has increased, that green on the top shows the percent of women having their surgeries done on an outpatient basis, which is steadily increasing. So in short, this is a very effective procedure, and doing it on an outpatient basis is very effective as well. So this is a webinar. We are keeping this very short because I'm sure everyone's distracted already, but I'm happy to take any questions at this point.
I know that when I let one come through, I just want to remind the folks on the webinar, you can ask questions in the Q&A box at the bottom, or you can send a chat if that's easier. I will give it just a couple, maybe a minute or so if anyone has any questions. And we appreciate you keeping this brief. I know it's getting to end of summer here.
It's 5 p.m. so I'm sure everyone's had a very long day.
You've just gotten a lot of comments, cute pictures. I love the cartoons. Here's something in. All right. If the person is up for same-day surgery, can they switch to patients?
Yes, and thank you. That's a great question. We, in no way, will make someone who is uncomfortable with how they're feeling before or after surgery. We're not going to kick someone out that's feeling ready to go. This is certainly an option for people to have if there's any concerns about staying at home, if you don't have adequate help in the house, or if you're concerned about nausea, pain, things like that, and those are very valid concerns. Or if you just don't feel like driving home, or if it's late or you have a far drive, things like that, we typically will do a one-night stay surgery where all those things that happen at home in terms of having a nurse see you, physical therapy see you, all those happen in the hospital the next day, and we check everything on those boxes, and if you're comfortable going home the next day, then we'll have you go home the next day. So that is a very easy thing to do.
Great, thank you. Next question is, what is the risk of infection? What percentage?
So it's very, very low. It's in the about 0.5 to 1%. And it varies based on which studies you look at. Our infection rate here is very, very low, and I don't have the exact number on me, but I do believe it is under 1%. But typically, you're looking at single digits under, 1% for most big studies for infections. It's very, very low.
Great. Next question is asking about the patient's stay in the PACU. Are they moved to another area to recover to help with the high volume of patients in the PACU?
This has been a work in progress. We are still working on where in the hospital we are doing this. Currently, we are having people in the recovery unit, or we're having them move over to the preoperative area, which is a little bit more private and works very well for recovery, and that gives physical therapy a little bit of room to work. For anyone who is familiar with the hospital, we are working towards moving to the South Snowflake area, and that will be its own separate area so we can have a dedicated recovery nurse to work with patients there. So that will be forthcoming in the next little while.
Next question is X-ray the only test used? What about CT or MRI?
It depends on what we're testing for. So if we are concerned about the joint itself with using an X-ray, sometimes we'll use CT, particularly back when we were talking about the post-traumatic arthritis. Sometimes there's a little bit more bone loss that goes into it. And sometimes you can have areas where there is some thinning of the bone, and it may be advantageous to look at that a little bit more with a CT. In terms of an MRI, if you're concerned about ligament instability, if you're concerned about anything with the cartilage, or if you're trying to do one of those partial knee replacements and you're worried about the other compartments of the knee, sometimes we will use an MRI to show that if we need to look at that a little bit more closely. In terms of studies, if we're going to do any preoperative evals on other parts besides the joint in question, so if we're looking at the lungs, looking at the heart, things like that, then that's where X-rays, sometimes a CT if we need to. MRI not as commonly utilized, but an echocardiogram or an EKG can also be used if we need to.
Great. There's a question about the use of anti-inflammatories for long term. Are they harmful?
So that's a tricky one. So yes and no. Most anti-inflammatories are over the counter, which means that they have a very high profile because you don't need to ask anyone or talk with anyone before you're able to get those. So those tend to be very, very safe. Now, it has been documented that if you take a lot of anti-inflammatory every day for very long, that can have bad effects. That can lead to kidney disease, that can lead to ulcers in your stomach. And so generally, I am not a big fan of the idea of being on anti-inflammatories for a prolonged period of time. I'm more on the book of taking them as needed. But again, they do have a very good safety profile, and oftentimes we'll have people on anti-inflammatory medication for multiple months, and people tend to do just fine with that. The concern is if you have comorbidities that can lead to not being able to tolerate anti-inflammatories while you're trying to do something there. And so this gets into a tricky area where if you have a primary doctor that you see, if they're giving you medications that you need to take, and then we're prescribing medications, that can be where medical errors can occur. Sometimes you have a doctor that you see regularly who's giving medications. We sometimes will default to that doctor to handle all of your prescription medication. Like one person knows what's going on and they have all the information instead of two people operating independently and not really sure what the other person's doing.
I have more questions about antibiotics, and then Mary Kay has a good question about, and it's going on to glucosamine.
Glucosamine brings on good studies that show they work. Now, some people, and when I get this question, which comes up really often, the thing now is I don't necessarily recommend for it, but I don't think it causes any harm if you take it. So if you try it and it works, more power to any harm in taking those. But there are not any high-powered studies that show that they work, as opposed to the steroid therapy is shown to work. In terms of anti-inflammatory medication is shown to work. In terms of alternative things you can take, there's turmeric is one that actually is shown to work. That is available in pill form. Places like Costco do not have a prescription to take it. You can also just use it as a seasoning and put it in food. There's a lot of recipes online you can get into a tea that also can work. So there's certain things that have high percentages of glucose, unfortunately not.
Good question about how long is the time for recovery if you're able to fully restore your use.
Once you fully recovered. So everyone's a little different. So once everything goes in, you are able to get weight on that joint. You're able to get partial, you're able to get weight, you demonstrate by having patients ambulate the same day. People are usually using assistance for walking, so whether you're using a walker, using crutches, using a cane, anywhere for 1 week to probably about 6 weeks or so afterwards. Part of it does depend on your pre-ambulatory or your pre-ambulatory status. So if you used the cane before, we're looking at getting you to use afterwards. If you did not use anything before, we're looking to get you back to not need any assistance afterwards. Everyone's a little bit different, and one of the worst things that social media has done for people is it allows you to judge yourself against everyone else. And probably the number one thing, same thing with dating sites online, everybody lies. So some people will say that they are a little bit further ahead than they actually might be because they want to impress people. And so, but oftentimes people are getting off their crutches or off their walker within a few weeks, which actually is fairly quick. In terms of getting back to activities that you would like to normally do, part of that also depends on your pre-surgery activity as well. One of the things we do not like people getting back to doing after a joint replacement is impact exercises, which involves running. So running is not a good option. It has a lot of pounding onto the joint replacement, and that can lead to breaking and to cracking of that plastic in there. Even though that's a very high durable plastic, if it runs, that does have potential break. Same thing with impact exercises. So jumping from height, high impact exercises can also lead to increased wear and tear. When we're doing these replacements, we typically expect them to last anywhere 15 to 25 years. The younger you are, the more active you are on a replacement, the more likely you are to wear it out sooner. So avoiding high impact exercises can be helpful to that effect.
And another question about there's an ideal age for a joint replacement.
So the ideal age is we aim to get to the age of not everybody's there, and it's one of the same idea. You just don't want to judge yourself compared to other people in the same age demographic bracket. Because some need wear sooner than others. Part of it is activity level, some of it is genetics, and you just can't, So 65 is ideal when you pass that age. I do not think there's an upper age limit. I was in New York and we were doing toys on people who are 80 years old. So I get that often people who are in their 80s say that, oh, I'm too old for a replacement. It certainly is something to think about where do you need one or not, and that is a decision I think is ultimately made up to the patient if they want to proceed with one. But age is simply a number, and the way we treat patients now is much different than how we treated patients at the same age 15 to 20 years ago.
Speaking of that, there's a question about the listeners feeling like you said that you'll use the same replacement in the past. I just want to agree if that's correct.
So between now and a few years ago, the techniques have evolved and become a little bit different. What I was alluding to before is we do the same surgical procedure if you're going to stay inpatient for a night or if you're going to go home that same day. The surgery on my part of the whole operation actually does not change. You would think the same way whether you were going to stay, whether you were not going to stay. The difference on doing outpatient surgery side of things lies more in the preoperative, getting everything ready in house, making sure you get your prescription filled ahead of time, any adaptive equipment that you may need, making sure that you have plenty of snacks in the pantry. I think it's a very important thing to make sure you have. And that is made, you don't have any laundry, you have to be in charge of doing things like that. You don't want to these chores to do after your surgery because that's not something you're going to feel like doing. So making sure everything's set up on that end is different, but in terms of surgery, it's the same. Now, compared to how surgery is done 5 to 15, 20 years ago, certain things have come along in and out of, things have become popular, things become less popular. So doing press fit knees instead of a cemented knee replacement, doing a smaller incision versus a bigger incision, how we close the incision, what we use in terms of how we wash out the joint and prepare things. Certain things have changed, and that's not necessarily part of this discussion today, but just to clarify that point.
You mentioned turmeric. Is there an optimal?
There really is not. They have, so at Costco, they have the pills. They look kind of like horse pills. It's one of those, I don't think you necessarily need to drink 5 turmeric teas a day, but it's something that basically having full servings of it helps with the inflammation on that aspect. But in terms of it as a set number, not that I'm aware of. There's certainly going to be suggestions on the internet that you can look at.
Great, and I'm going to combine these next two questions. The first is asking how long should someone expect to use a walker for, and then what are the chances of a blood clot during or after?
Okay, so those are both good questions. So in terms of a walker, that gets back to anywhere probably 1 week to probably looking at 6 weeks, and everyone's a little bit different. And again, it's not a race. There's no award for being off your walker first, but everyone just sort of has a little bit natural your pre-surgical status. It also depends on where you live. Do you have a lot of stairs in your house? Do you have an incline? You know, do you have more help around the house? And oftentimes there can be a little bit of a back and forth. You walk not entirely off of it if you go out and go to the store or go, do errands and chores. You may be needing to use a system that someone can relax a little bit more and doesn't need to get around quite as much. So there is a difference in there, but there's quite a bit of variation between 1 week and 6 weeks around that. And then in terms of blood, that's also low. That's in the one use. If with that, we get that anti-medication that we give patients. So standard what we'll do if people don't have any comorbidities or medical factors to develop clots, we'll simply use aspirin. We use aspirin, we use big aspirin, and we'll do that twice a day. If people have a predisposition to clotting, whether genetic or whether they've had clots in the past or any other type of injury, we might use a little bit of a stronger anti-clotting medication.
And I just enjoyed using Medicare. How that works for total claims. Anything?
So they've changed how they pay these things quite a bit, and it's always in flux. And one of the nice things working at Barton is that's something that typically as a physician we don't have to worry about, and as a patient you shouldn't have to worry about as much as well. Because what we do before we do a surgery is we submit it to make sure that it is covered by an insurance company. Otherwise, if you don't make sure you do that step, then the patient gets stuck with some ridiculous bill, and that's what we want to avoid. So we make sure that it is authorized by the insurance, that they agree to cover the costs of the surgery, minus every individual plan has some contribution from the patient themselves. And so that is something that on our end, we focus on treating the patient. So what we'll do when we see a patient, we've gone through those non-surgical options, we've done activity modification, we've done a couple of rounds of physical therapy, we've done injections, as many as we need to do, or as long as they're effective, we'll keep doing that. And when it's time to have that conversation about doing the surgery, we'll submit that to the insurance company to make sure that, hey, here's the plan. It doesn't make a difference if it's going to be an outpatient surgery or if it's going to be an inpatient surgery. And that also is nice that if we get it authorized to do the surgery, we plan to do it outpatient, and then the day of surgery, after surgery, you just don't feel quite comfortable going home. I still feel a little nauseous. I'm worried about my pain or any other concerns. It's going to rain outside. That might keep you from wanting to go home. That doesn't change the possible. It doesn't change what your bill is going to be.
And there's a couple more that came in. I thought were good. If you have a couple more minutes, you both need time.
Yeah. So again, that's the question. So short answer is yes, you can. And I'm doing one of those at some point. And we do those every now and then. And there's a few reasons why you want to do that. One, sometimes that's a popular request with patients to just say, hey, I just want to do one surgery. A word of caution with that, this is one of those situations where 1 + 1 does not equal 2, because it is a little bit difficult with physical therapy, with pain control, to have two post-surgical needs that don't have a good need to lean on per se. And so it's a little bit more difficult to get going, and people that requiring assistance for ambulating a little bit longer. And the more nuanced part of that is if we're doing a double knee replacement, that is not candidate for an outpatient surgery. So we'll do them, but we'll have to spend one night just because of increased pain control and difficulty around things like that.
Okay. Last question is asking about if there is a machine that a patient can rent that can relaxes in circulate water. I'm guessing for the recovery.
There is. So there's a couple different options for that. One is called a Game Ready, where it circulates cold air around, and then there's also an ice pack that'll be over it almost looks like a brace that you can put over the mouth. You put cold water across the knee, and that'll help calm down some of the inflammation and some of the pain after surgery as well. And those are both good options that we can offer patients as well. And that's certainly something that's a good question for when you have a pre-surgical talk with your doctor.
Wonderful. Well, that is all the questions that I see. That was, I am really impressed with all the different questions that came through. So thank you for the engagement. And thank you, Dr. Orr, for taking the time to be here tonight to educate us on same-day joint replacements. I hope everyone has a wonderful evening.
Thank you, everyone. Those are very good questions. Thank you for tuning in.